This is a brief presentation titled Rib Number 9, Mobilization, Basic Concepts. And this is a video made for a professional who contacted me. I made the offer on a LinkedIn PT group. And I'm Jerry Hesch at the Hesch Institute in Henderson, Nevada, close to Las Vegas. Our website is heschinstitute.com. And we are active in education, and we have a clinical practice. And we'll begin without any detail of the case, other than to say that it was a gymnast who apparently sprained a rib joint, and we'll make the assumption that the thoracic spine has normative mobility in the thoracic facet joints. And counting up from the bottom, I like to dig into the soft tissue and fairly medially to find that short rib number 12, which is, fairly deep, sits deeper than, the ribs just below the scapula. So counting up, that would be number 9 right there. And I'll do my best, I'm by myself here, I'll do my best to keep the image fairly competent. All right. So at rib number 9, it abuts the disc somewhat, and otherwise abuts, of course, the transverse process and the facet on the vertebral body. And this joint is shaped very much like a finger. Now it has a beautiful little curve, so it does. Not just curve in, but it curves in and then it slopes down rather abruptly. And I surely can't capture that with a camera, but so be it. So if you take your finger and you bend it just slightly, then that is quite similar to that joint. So the question begs, is this an appropriate time to start mobilizing the rib? And based on the conversation, it certainly does appear such. And if general exercises fail to do so, and a specific mobility test affirms that it's appropriate, then moving forward and having evaluated and treated the client for a short while and having a clear picture that it is appropriately indicated, then what I favor doing with ribs is to first gap them. I like to gap the rib joint. I also like to make the assumption that I don't know if it's compressed medially or laterally. And my rationale for that is that we can't treat something based on how it looks. And it may look like it's compressed medially, or it may look like it's lateral, and honestly sometimes it's too subtle to make that discernment. We can test mobility though. We can come onto the rib and approximate the general slope, okay? We can test it here, or we can come out here and test, can I move this rib into what I will call internal rotation? Can we do the same ever so carefully going anteromedially? Okay, so if we were to go on the lateral portion of the rib, the angle is going to be more like a 30 to 45 degree angle. Okay, if we're testing the medial mobility, then it's going to be more like a off this plane, dorsal plane, it's going to be more like a 20 degree angle. Okay, so you can palpate the interspace between the ribs and isolate that rib. And so that test would be to go medially. I'm ever so cautious anytime I spring it medially, because it's a very tender rib. Patient perceives tenderness, much more so with a medially compressed than a laterally fixated rib. Okay, so with respect to the distraction, what you can do is come onto the rib. You find the spinous process, if you're able to, depending on body type. Otherwise, you have to make some assumptions and come out a little bit more laterally. But basically, if you're right in the middle on that rib, then if you push straight anteriorly, you won't succeed. You're going to actually compress it against that vertebral body and disc. you have to angle it laterally at least 20, but I would favor 30 degrees. That will distract it, and even more so with, say, 45 degrees. So that is a safe direction to distract it. And so by simply gapping the joint and maintaining that for a while, assuming that it's comfortable, assuming that the patient is giving you positive feedback, that yes, that feels like it is relieving pain and tension and so on, I prefer to stay for 2 minutes. It's a personal choice. That is my choice. And I just find that the treatment lasts, the benefits last much longer when I use prolonged holds. Okay? So if that was a direction, then gapping it for about 2 minutes is therapeutic. It's also the same direction to mobilize it laterally. Okay? If the rib, and we don't know exactly how the force is netted and how the trauma and joint shape and all of that and muscles facilitated and so on create the whole pattern that we're seeing, but let's just make an assumption that if the rib was elevated, and you can say that it's moved up in the joint or muscles are pulling it or a number of things, but what you want to do is test inferior glide. Okay? What does normative rib mobility feel on this person? Okay, when I go inferiorly, well, you can't get underneath it, so you have to go at about a 45, realizing one vector is posterior to anterior and one is inferior. Okay, so we come up to the 9th rib, and let us assume that in this example it's elevated, which would be more probable. It's quite rare that a rib this low in the body gets stuck inferiorly. Number 12 is an exception to that. Let's assume